Good afternoon, ladies and gentlemen, and welcome to today's edition of the Healthcare World series. My name is Steve Gardner. I'm the Managing Director of Healthcare World, and I'm joined today by a fantastic panel to discuss the concept of value-based healthcare and what it means in different systems around the world. Value-based healthcare is, of course, one of the big buzz phrases of 21st century healthcare, the move away from volume-based payments towards value-based payments in some markets, even things like the NHS, where we start with the idea of government funding and we try and drive value through that. There are lots of different ways of looking at what we mean by value-based healthcare, and in developing payer systems like those of the Middle East, it can mean something quite different again. So I've got a fabulous panel to talk about this today, and I'm going to be fascinated to hear all of their insights. Joining me, I have Dr. Mohammed Al-Abaidli from Patients Know Best in the UK. I've got Professor Jed Byrne, the International Director at NHS England, who is dressed in scrubs and waiting for a patient to come into theatre because he's also a part-time surgeon as well. So hopefully he'll be able to join us for most of this. Stephanie Jovinger, who is the President of Research and Education at Skåne University Hospital in Sweden, is representing mainland Europe. Jason Helgeson, the founder and CEO at Helgeson Solutions Group and a former Medicaid director in the US, will give us an insight into how the US sees value-based healthcare. Sultan Al-Shamrani, who is Population Health Lead for the Health Holding Company in Saudi Arabia, joins us to speak to bring the Middle Eastern perspective. And Ben Furno from Cigna, also working at the moment in the Middle East in Saudi Arabia, but representing not just the Middle Eastern, but the global insurance market. So, gentlemen, great to have you involved in this session. I think the easiest place to start here is to just ask the question straight up. What does value-based healthcare mean to you and in your system? And given the fact that Jed could be spirited away at any moment, Jed, would you like to start by giving us the definition of value-based healthcare from a UK NHS point of view?
Thanks, Steve. It's great to be here, and apologies, I'm almost certainly going to have to leave for an unknown period of time at some stage relatively shortly. So I'm a surgical oncologist by background, so I'm going to talk from just a couple of sentences on both the perspective of a frontline clinician and a perspective of a universal health coverage leader. So from a frontline clinician, I think value-based healthcare is all about transparency and individuality. And I think it's a move away from calculating cost on the basis of block and tariff-based healthcare, which the NHS has engaged in for most of its 75 years as a universal health coverage system, on which we know through data analysis, and as we get more and more large data, is quite an inefficient way of ensuring value for money and of individualising treatment for the patient. On a national scale, I think it is a way, it's a very interesting way, a financial way, if you like, of describing quality. And certainly in the NHS, and there's always a risk, isn't there, with these buzzwords or these buzz phrases, that they mean different things to different people and therefore mean nothing to anybody ultimately. But I think from a national perspective, a leadership perspective, it stresses and allows us to think about, through the transparency of data and through the transparency of cost, allows us to think about what individual healthcare delivery quality is, whether it be patient pathway based, individual community care delivery, or transitional care between community and secondary care. So I think certainly as an aging and often creaking universal health coverage system, I think value-based healthcare and thought gives us a new way, or a new way of thinking about how we fund and how we deliver high quality healthcare for our population.
Just on that, Jed, I mean, is the UK a value-based healthcare system as such? And what I mean by that is, do we almost, because of the nature of the centrally funded NHS, we do value-based healthcare by mistake? Because we have difficulties in terms of budgets, difficulties in terms of funding. We drive value, but not in the same way that, say, a US insurance-based value-based healthcare system works. Is that kind of where we sit?
Yeah, well, I mean, it's a real paradox. As I've thought about this a lot. I mean, I'm in a trust at the moment that's recently introduced the Epic software, Epic EPR, and Epic EPR, of course, is based fundamentally on itemized costing. And itemized costing is highly anathema to the UK NHS. It's very, very confusing to think that individual items in healthcare may actually have a value. And certainly most frontline clinical staff do not pay a huge amount of attention to value. There are, of course, benefits in them gradually understanding the value of some of the equipment and the techniques and the productivity that they indulge in themselves, in terms of being able to self-monitor and group monitor at the front line in order to drive down cost and improve quality at the same time. The risk, of course, is that, which tends to happen within the NHS, is that everything becomes about cost rather than about quality. And likewise in the States, and certainly my experience, which is limited, admittedly, in the US healthcare, is there's a risk of doing it the other way around, is that you can drive up the cost to the end user and therefore revenue by itemizing and focusing on the value base. So I think we are probably by default value based, but I'm not really sure that that's necessarily a good thing, Steve. Whereas I think a system which is conscious right from the word go of value at the front line is likely to be much more of much higher quality and offer much greater value for money than one that is forced to drive down cost because of national politics and overall national budget.
So I guess from that perspective, the other question that comes in where the UK is concerned is the one about, is there ever a situation where you can see the UK moving from the system, the system we have at the moment, to being more cost conscious and driving that kind of itemized billing? I think I described this. I was at a conference a couple of months ago where I described the UK payer system as being the magic money trick, because no UK doctor ever looks at a patient and thinks about what the cost of treating them would be. Are we ever likely to move to that model, do you think?
So my comment on that is that we're going to have to, Steve, because we can't afford to do what we're doing at the moment. And I'm not going to get into a political discussion here because I'll only end up once again on the naughty step. But what is perfectly clear over the last 25 years in our version of UHC, and I think it's probably true of most Western healthcare systems, is productivity levels have dramatically dropped. And that is making, together with an aging population and an aging average population, is meaning that we cannot either attract the workforce or afford to pay for a healthcare system. So one has to look at ways of driving down cost and improve, and that has to be through improving productivity. And the only one of the ways of doing that, of course, is empowering the front line to save, to innovate and save money on the front line through a value-based system. So I think it's not a case of whether it will become one. I think it's going to need to become one in order to survive.
So that's the UK perspective. Let's go right to the other end of the spectrum, and Jason, the US. And I've often been heard in these kind of debates to discuss the idea that if you look at payer systems as a whole, the UK is at one end of that spectrum, where cost control only takes place at a national level, where the US, everything is costed individually. Do you want to talk us through what value-based healthcare, what the payer system looks like in the US, and then how value-based healthcare is establishing itself there?
Yeah, sure. First, I think it's a great question, and I'm glad to be on this panel to hear the perspective from people from different parts of the world. And I believe at the end of the day, value-based care is a movement, or it should be seen as a movement. It should be about thinking about outcomes, which is better outcomes for patients, but also better outcomes for the population. And then also trying to achieve those objectives within costs that society can afford. And different societies, different countries will in essence define what is affordable in different ways. Now, the US context is we have in essence, decentralized, although probably less decentralized than I think is sometimes appreciated, in the sense of we have a multi-payer system. So we have commercial insurance companies, and then we also have large government programs. And what's also interesting, I think, misunderstood about the US system is this assumption that it's all private. Reality is that government, through the two big healthcare programs, which are now, both approaching $1 trillion of expenditure a year, Medicaid and Medicare account for about half of all of the money now in the American healthcare system. So while healthcare isn't entirely funded by the federal government, it's fast approaching the majority funding source, which wasn't necessarily the case, say, 20, 25 years ago. So the government does play a very significant role in financing the American healthcare system. So I would say is that I'll start with what I would believe the definition of value-based care should be, which is that kind of what I just said, which is that we focus on outcomes both at the patient level and at the population level. And we seek to see improvement, measurable improvement using true outcome measures in both those areas. And at the same time, what we're looking at in terms of costs is really avoidable costs and reducing avoidable costs in the system. And I emphasize avoidable because I think sometimes and this is one of the dangers in value-based care, is it becomes we're just going to control costs. And what that ultimately can mean is controlling costs in things that shouldn't be controlled, things that we should spend, frankly, more money on. In the US is a good example. We spend a tremendous amount of money on, very highly specialized, acute episodes of care, sometimes end of life, sometimes for treatment of very, unique, complex, serious illnesses. We spend a lot of money in those areas, but we tend to spend, especially compared to other countries, a lot less than other countries when it comes to things like primary care. We should spend more in primary care. And so I think we have to be careful that what value-based care, in my view, really should be is about measurably improving outcomes for patients and populations and trying to squeeze out that inefficiency, that avoidable cost, or I sometimes refer to it as is bad variation. Things that are happening out there in the healthcare system, services that are provided that are ineffective, avoidable, duplicative, and such, or that frankly just don't work, that don't achieve the objective. They aren't the right treatment or such. And in the US context, for better or worse, there's a lot of that in our system. We're probably the least efficient healthcare, and I would argue, I don't think I have to probably argue it too aggressively, is we're the least efficient healthcare system in the world. Almost 19% of our gross domestic product is the richest nation in the world going into our healthcare system, yet our outcomes, look like countries with, half the GDP per capita of the United States have outcomes, at least in the population level, comparable to ours. So, and some estimates suggest as much as a third of our total expenditures as a nation healthcare are, in essence, this avoidable type of expenditure. So there's a lot of opportunity in the US context for efficiency. The last thing I'll say is, unfortunately, I think in the US, we tend to define value-based care in a myopic fashion. And this is a reflection of the fact that we are a decentralized healthcare system, both from a payment standpoint as well as from a provision standpoint. And so, unfortunately, I see in the work that we do all the time, with mostly on the provider side of healthcare, is it ends up, we define value-based care very much around a small subsets of patients in the relative scheme of things, a very specific set of outcome measures that tend to be mostly process type measures, not true outcomes. And cost is just around those particular patients and their needs and the services that they're receiving from that group of providers. Now, we should look for efficiencies in that way, but what we oftentimes lose is the big system. The idea of thinking holistically in a geography, or even as a nation, how can we get to a more efficient system? I think that's an advantage of the nationalized systems like the UK, is that it's easier to have that national conversation. It's easier to think more holistically. And that's why I say I would critique our value-based care in the US as being too narrow, too focused on individual groups of patients and individual groups of providers. But I look forward to our further discussion on this important topic.
So just to sort of feed into that a little bit, you talk about the idea of value-based care as a movement. And I guess in many ways in US healthcare, it's both a movement and a journey. Just give us a sense, if you can, of what was the starting point for that journey? Why did value-based care become important? And what's the ultimate goal? What's the ultimate destination for that journey?
Yeah, so it goes back to if you want to go back all the way to where did this all come from? I would argue that it goes all the way back to the 1970s to Professor Alan Enthoven's theories about competition in healthcare and how you could create, in essence, systems of care that would, in essence, compete with each other based on value, and that those systems would, in essence, be paid in sort of a global budget type of construct. That thinking led to the rise of health systems like Kaiser Permanente in California, which a lot of people have pointed to over the years, Geisinger, Intermountain, a variety of different systems. And there was a hope, I think, for many years that those systems would have, and the whole healthcare system in the US would evolve into that situation. That really, in fact, never really has occurred. And I think what this idea of integrated delivery systems, integrated delivery networks, is in this idea of them all being sort of one employed unit, providing a full range of services. That is significantly the minority of what is American healthcare today. The vast majority of American healthcare is companies like Cigna operating as a health insurance company with a network of providers who they do not own, that they're paying for services. And I think the reality of value-based care today is how do we pay those providers in ways that encourages them to collaborate where it's needed, to work together, to see the patients and the population's outcomes as a common objective, incentivizes them to be as efficient as possible. And I think what is key, and you mentioned this, Steve, up front, which is to move away from a reimbursement system, which is, I think, been the bane of our existence and the driver of a lot of the inefficiencies in American healthcare, which is move away from volume-based payment. And Jed gave good examples of paying for individual units of care encourages ever more units of care, whether that's what people need or not. And so I think by moving away from that system, and it's a hard slog, we're probably about 30 to 40% of the way to where we need to get to. It's complex, and it's probably not moving as fast as we want, but I do think that it's inevitable. I think the fee-for-service will end in the US, that the vast majority of providers will be paid in other methods that will link their reimbursement more to the total cost of care services provided and to the outcomes for patients. And I think we're going to get there, just slower than many of us would have liked.
I want to give Ben the opportunity to respond to that from an insurer's point of view. But before I do, is there not an issue here because of the decentralized nature? And this is probably for both Jason and Ben. Is there not an issue in the US because of the nature of that decentralized healthcare system around perverse incentives, around the idea that providers will provide, in some cases, unnecessary treatments or do too much treatment of a patient simply because of the nature of the fact that that's the way they get paid?
Yeah, I would say is that a critique of value-based care, or a concern that's raised about it, is that it creates a disincentive to provide services, that it potentially flips the incentive, which is that the way I can make more money or increase the margins of for my organization is to deny care. And that is a concern, I think, with any reimbursement system that is a sort of a global budget capitation, whichever for words you want to use to describe it. That's why I believe at the end of the day, in value-based care, you need a balanced scorecard. You need reimbursement that is linked both to outcomes and to total cost of care, so that you have better aligned incentives, where if you don't achieve the outcomes that are important to the patient or to the population, then you don't get to capture savings, even if you lower total cost of care. But I would say, last thing I'd say about this, and interested in Ben's thoughts, is no system of reimbursement in healthcare is valueless. They all have values. They all are a reflection of society's values, and and whether or not it is explicitly stated when a country implements a system of paying for healthcare, that system reflects the values of that society, whether they admit it or not. And I think the issue in the US has been that we have our values have reflected this idea that payments should be for units of service, and the more units you provide, the more you get paid. And that system has had consequences. Yes, it has led to advances and a lot of research and a lot of new technology and new treatments, which are, have benefited the world in many ways. But it has also led to unintended consequences, which are real and impact both cost and quality, like what I said before, which is the massive underinvestment in primary care that we have as a country. So I think at the end of the day, is every country, as we think about value-based care, is not just to look at what the consequences of the new system are, but what are the consequences of the existing system? And how does the existing system of how you pay for healthcare reflect your national values? Or do you need to adjust that system to more closely reflect where your priorities are as a country?
Thanks for that, Jason. I think it's fascinating to hear that whole concept of the US system going from kind of over-treatment with a volume-based system to under-treatment with potentially under-treatment with a value-based system. Ben, I want to bring you in on this as an insurer, not just obviously experience in the US and in the Far East and in the Middle East. What's your perspective on this? Let's talk about that US system a little bit first.
Yeah, Steve, thank you very much. And I have to say that Dr. Byrne and Jason have had some great points here, and none of which I can disagree with. I do work for Cigna. I'm on the international side. I do not work in the US, but I do have some knowledge around it. But what I would say is, you talk about the national identity and who each country is. And as you mentioned, 50% of our spend is coming from the government versus the other 50% on the private side, and how to be able to make sure that through the guide rails that are there, and on the government side particularly, and making sure that there is affordable outcomes that are occurring with the right health outcomes is really important, and that the waste is not pervasive. And we do see that. We see that around the world. I'd want to kind of bring ourselves outside the US for a little bit, but there are going to be aspects that can go back to what Jason had spoken about. I mean, first and foremost, as an insurer, and particularly as a health insurer, at the core of our mission is to be able to make sure that we're able to keep our members, our customers healthy, and play our part in doing that. Not just paying the bills, but making sure that we can have the right programs in place, making sure we have the right clinical and technology aspects to it, and being able to keep up with what's happening in that medical system, in the society, and what is affordable in the societies that we're working with, as you had mentioned about, Jason. And so that's really important to us to be able to get those right quality outcomes. With that said, we also have to really focus on affordability. And so when you walk through the US's journey and how we've got to that place, I think I'm seeing this in many other markets that I've worked in around the world too. The national identity is about being able to provide the right outcomes for its members and its citizens, but also to be able to encourage the economic model that they want as well. So there is that private side. With the private side comes margin. There can become greed as well. And it's important as us within the healthcare professions to be able to make sure in this ecosystem that we're able to make sure that greed does not become so much that it is out of control, and that we're able to have the guardrails in place. And we're seeing that in markets, particularly in the Middle East, starting to really create that, which I'm encouraged to see, where you can still have a private system that is able to have, private components to it, but still be able to allow for good quality outcomes. On the affordability side, what I just want to, talk about a couple things here. One, between 2000 and 2017, in a study that we have, global health spending grew on average by about 4%. In 2020, with COVID coming out, we saw that there was roughly about 36% growth in global healthcare spend. However, obviously there was a 3.2% reduction in GDP. So we had that increase that happened. We have not seen a decrease happen when it comes to medical spend and medical trend. It's always outpacing GDP. It's always outpacing inflation as well. So it's becoming more and more unaffordable for governments, more and more unaffordable for payers, and then our clients and our members, our customers, to be able to afford the best outcomes they could possibly have as further technology innovations occur, pharmaceutical innovations occur, and the price points continue to increase along the way. So our big part about value-based is not about cost. It's about how do you deliver and optimize the healthcare outcomes at an affordable, while improving affordability, I would say. So that's really what I would want to bring out in all of this here, is about some of these market realities of affordability and being able to provide with the new technology to the society that we're being able to represent the right outcomes and be able to allow them to live healthier lives.
Thanks for that, Ben. I think great to hear that from the private sector insurers' point of view. Let's pivot again towards more of a socially government-led system, as I understand you have in Sweden, Stefan. Do you want to talk a little bit about your system and what value-based healthcare means in Sweden?
Yeah, so it's both of them actually. The majority of the primary care is privately provided, but the mainstream insurance to everyone is a public insurance. So I usually refer to as your automatic and overall insurance. So you don't need to fill out any forms as soon as, well, your tax forms, that as soon as you become residential, you are being insured. The special twitch to Sweden compared to NHS is, I think it's more of a private provision, and they compete for this money as well. But it's regionally organized, and Sweden has the same size in population as Michigan, so 10.6 million, which and still there are 21 regions, of which each region is fully responsible for the insurance of the people in that region. And value-based healthcare, I agree very much on Jason's conclusion. It's a movement, and it has been a very, very important movement, because even in Sweden, volume-based has been prioritized as a healthcare. But one thing that has stood out in Sweden, that there have been, since it's a one healthcare, a dominant healthcare provider, the public, that data on quality registers are available on a national level. And that has been used as benchmarking. An interesting trend, I think the outcomes of the Swedish healthcare are on top of the line, whatever you look at. But the problem is a lack of incentives. So if you look on availability, it's not on top of the line. It's actually on the very lower end or in Europe. It strikes out as and this is very much a segment which private insurers have been taken into account, that you can top off your public insurance so that you get your hip replaced within 3 months rather than 9 months, and so on. That has been, but what has been discussed is, of course, how can a small country like this have 21 regions? And there are movements on doing less regions, or doing more nationally highly specialized care, and that has really happened. So diagnoses, which you would be surprised, are being required a national license. And that means that not all regions provide care for that. And that is based on the outcomes of the different centers and the academic centers. And that is based on the value and the outcome of those centers. That has been a new twitch to the system, as I would say. But I think that what in many instances, even in Sweden, has been a vision. I think technology has come to the point of big data where it's not the vision anymore. You can get these data, you can guide your provision of care in a more efficient way, and value-based care is much more possible today and will be even more possible in the future with all, and that is all what is a big focus in Sweden, AI and big data lakes, to be able to provide the data you need to optimize the care. Value-based care in Sweden has had the effect of organizing care in flows, multi-specialist flows, which seems from a theoretical point of view being excellent, that you don't only think about oncologists when you have cancers, you have to think of surgery and so on. But if you are not the patient which perfectly match that flow, you still run into problems. So I think that care in Sweden is being organized around data more and more, and that is what more and more see as the possibility to guide through and make it more efficiently, because we have limited resources as anyone else. And as you see in economic systems with lack of incentives, you will build a line, and that's exactly what happens in Sweden, that if you don't have competition enough, you will and incentive enough, people will need to wait longer for care.
So developing a kind of market-driven system creates a situation where you don't have enough care in some of those areas where there's less demand. Is that what you're saying?
Yeah, and one problem with value-based care, if you are in a region which has lesser resources for a certain type of care, you might be less off than in another region, and that has been compensated for. So you can actually forget the provision of care abroad if you are not being given the care within a certain time limit. But first of all, if you're not given with that region, but yeah.
So in terms of the payment model itself, you're talking about a system which is publicly and privately funded, but publicly funded to a great degree, but the provision is private. So do you operate, and it's done on a national insurance
I think they're mostly public provided, except for primary care. There are private hospitals, they are more rare, but all the academic centers or the advanced treatment centers are publicly provided care. But when the regional government, who sits on the largest pot of health insurance, they buy care where they find it best. They are not all in for public. If a private hospital or private orthopedic surgery group does it to a lesser price more efficiently, they will get it.
So from that point of view, is it, we're looking at the kind of concept of value-based care here. So are those spending decisions by the regional governments made on the basis of, is it volume-based or value-based payments? Is it outcome-based payments in Sweden?
I would say it differs, and one of the problems which we haven't touched, if you would say, Stefan, what makes you sleepless at nights, it's not the Russians coming and trying to invade. It's about the competence of nurses and so on. And what happens is that private providers will pay more, and then public providers will have difficulties in providing the care, and then you buy the care from private providers, which took your nurses at the higher price and the price for care. So it drives care, the price of care. But I would say that it's a combination. They want a certain volume, but they will keep track on you based on the quality registers if you meet up to the basic qualities.
It's an interesting point you raised, and we'll come to the drawbacks of value-based care in a moment. But just on that point about workforce and having the right level of workforce and their sort of payment model, I won't mention which country it was, but I did have some experience working with an NHS organisation in overseas territory a few years ago, where the NHS organisation was supposed to be overseeing and helping to design the workforce model for a hospital in a Middle Eastern state. It wasn't Saudi, so don't think it was you guys. But there was a whole issue where an NHS hospital pulled out of doing this piece of work on the basis that they considered that the hospital, which was privately funded, wasn't safe by UK standards because they were driving the commercial model and they weren't having enough staff. I guess that's one area where there could be an issue around the value-based care system. Move on from that, and I want to, because I think this is quite interesting, something I'm going to come to you last, because I think the Saudi model of what value-based healthcare could potentially look like is fascinating. Mo, I want to come to you next. I mean, PKB, obviously you are a patient-facing, patient-advocating company and product. So I really like to get your perspective, the patient's perspective from you. What does value-based healthcare mean to the average patient?
Thank you, Steve. I'll say three quick things. One is being able to get the true value from the patient. So if you have an operation, it's not just measuring at the end of the operation what the range of movement was, but actually I could tell you how much they were walking 6 months before and 6 months after the operation, just by getting that data off their phone and then providing that population data for outcomes, what actually happened to the patient. The second thing is the patient choosing the outcome that really matters to them. Just before this call, I was with one of our Dutch customers, which has built something with the Dutch government for chronic lymphoid leukemia patients. So they have a website that takes the latest guidelines and the latest outcomes and asks the patient what biological situation they're in, including what genetic situation they have, excuse me, and what preferences they have about treatment, pain, quality of life, and so on. And then gives them the option. These are the 5 treatments you have, and given what you've said, this is the pros and cons of each one, and then ask the patient to choose which of the 5 they like the most and explain why they like that particular approach. And then it stores that back as a care plan in patients know best, which then gets taken to the physician to say, based on the latest guidelines, the evidence base, as well as my personal situation and my personal preference, this is what this is what it looks like the best thing for me. So that's actually choosing the personalized outcome rather than the brittle. We're going to have one outcome for the whole country. And the last thing to say is, given that most conditions today, what the patient does is what matters more than what the doctor does. Do they take the medication? Do they do the exercise? They change their diet? Actually, the patient is a key part of the outcome, and them understanding the data and the behaviors and the actions they have to take changes the trajectory of the outcome more than the doctor's prescription or operation does. So for all these reasons, we look at the patient being so critical in the value-based healthcare movement, that we can get the real outcomes from them. They can choose the outcomes that matter to them, and they determine the outcomes with their behavior.
So I guess the question that leads out of that is, does a patient and should a patient understand what value-based healthcare means to them?
So I do think that healthcare and other sectors like education, the fundamental, the original sin is that the beneficiary is not the payer, right? The patient doesn't pay the costs, but they do get the value that comes at the end of it. So a lot of the sort of decision aids that we try and inform patients about aren't about the cost to the healthcare system, because with universal coverage, we're trying to take that price away from the patient, but it is trying to explain to them that what value will you actually get from the operation versus the exercise versus the stick and so on. So explain that value to the patient and letting them choose what matters to them and explain their contribution to that value. Absolutely, that has to be in there.
I think we'll come back to that one as we go on into the kind of debate element of the conversation, and how you link the patient's desired outcome to the way that insurer pays for the product will be a fascinating part of the conversation. But I want to bring Sultan in and to talk a little bit about the healthcare transformation in Saudi Arabia and what you mean, or what your expectations are of value-based care in your country. And I think for me, Sultan, this comes to the fascinating element of, I've been doing a bit of work in Saudi for the last year or so, and the fact that you're developing pretty much from scratch your new sort of public health system. Listening to the different examples you've seen here from the US, from the UK, Sweden, what have you, as a country, what have you understood about value-based care, and how are you going to implement, what are you taking away from that? What are you going to implement in Saudi Arabia?
Thank you, Steve. So the Kingdom of Saudi Arabia is implementing a comprehensive health transformation as a part of the National Vision 2030 programs. So the goal of this transformation is to improve health, improve healthcare, and improve value. So the value-based care, or improving value in health, can be defined as achieving the best health outcome with optimal and fair allocation and utilization of resources. So in this context, maybe it's a little bit different from, for example, Porter definition. So outcome is referred in the Saudi context. Outcome referred to the benefit delivered for individual, communities, and population. So we add the communities because it's a part of the wide system transformation. And also the resources, we mean by resources, it's the human capital and natural resources. So our definition want to focus on capture the system-wide and population level aspects that are critical to the Saudi health system. Unlike, for example, Porter definition, because he focuses on the clinical meso and micro system than more than the looking at the whole system, because the transformation in Saudi Arabia is huge and big, and we want to look at all aspects of the population.
And how is this going to look to the average Saudi Arabian citizen? Is it a free at the point of delivery healthcare system like the NHS? Will it be a national insurance program? Will they pay for insurance? What does this look like to the average Saudi in terms of the way care is paid for?
Yes, so we are still in the beginning of the transformation, but I think we are in the right way, because Saudi Arabia already established a health holding company. The company is going to develop a 21 accountable health organization. The accountable health organization will be accountable for defined population, and they will have their own budget. And also established CNHI, or the Center for National Health Insurance. And this company, it will be the responsible to buy the services from the provider. And also they established the value-based center. So we are trying to prepare the system to move from the current way of delivering healthcare to better way for delivering the healthcare, which is most important for the patient, is the health outcome. So we are trying to prepare the system so that the provider will try to do their best to improve the quality of care that giving to the patient, and the payment system will also try to focus on encouraging the provider to improve the outcome and incentivize them based on their performance and based on their health outcome of the population.
So as I understand it, you've got a situation where the clusters, which are now forming as the ACOs, under the health holding company will initially be centrally funded. And then over a period of time, you're going to move towards a national insurance model. Is that right?
Yes, exactly.
And the provider organised themselves, are they nationally owned? Are they government owned, or are they private sector organisations, the providers?
Right now, still they are under the government, but the plan is that in the future there will be a private company that's responsible for a defined population for the 21 accountable health organization.
So the clusters will ultimately become private organisations.
Yes, yes.
Yeah, and they will get their funding from government through the CNHI.
Yes, the government will, the money will go through from the government to the health insurance company, and the health insurance company will buy the services from the provider.
And is that the, and of course within Saudi Arabia you've got multiple different, you've got a public system, but you've also got private health insurers, haven't you? What role will the private insurers play?
Right now, the private hospital, they have their insurance system, so they are not involving with the transformation right now. But later on, for sure, we need the private sector to support the transformation and to support the population in regard to providing the healthcare for the population.
So from your point of view, obviously you're responsible for population health and the development of population health models in Saudi Arabia. What role do you play in terms of the kind of data that you're collecting and what you're using in moving from what I guess at the moment is, because it's centrally funded, a free at the point of delivery, straight budget pay healthcare system towards that national insurance system in the future? The data is going to play a massive role in that, isn't it?
Yes. So the population health management is very important for the value-based care model, because the population health management will focus on identifying the population and then try to collect data to segment the population and stratify them based on their risk. So when we segment the population and stratify them, we can identify the high need, high risk population. And then the provider can design a clinical pathway with the right outcome measures so that we can improve the health outcome by measuring the right things, because some of the healthcare organization focusing more in measuring the process more than the outcome. So the BHM or population health management will segment and stratify the population and then design a clinical pathway. Also, the BHM can help in care coordination, because essentially we want to coordinate the care between the provider, because right now a lot of care is fragmented. So we want to coordinate this care. Also, we want to be the patient in the center of the care. And this is what we can do in the BHM, plus managing the chronic disease condition by doing health education, proactive intervention. All these things we can help and support by using the population health management approach.
So I guess there's an interesting one that we could kind of throw out to the rest of the panel here, isn't it? Which is, how much does the quality, availability, and ability to correctly use data allow us to drive value-based healthcare? Jason, do you want to maybe speak to that one from a US point of view?
I mean, I think data is crucial in the sense that value-based care should be about proving outcomes. But if you don't measure it, you won't focus on it. If you don't measure it, you have no idea whether things are getting better or worse. And I do think that, any nation that wants to engage in value-based care, I think really needs to start with what are the goals, what are the measures that we care the most about, and how do we collect, then once you decide that, how do we collect data systematically on those, right? So we can measure whether or not we are making progress. And I think sometimes what happens is that we tend to focus a lot on the payment mechanism and we kind of skip over what are the measures and outcomes that we're trying to achieve. I mean, I would say a little bit of, I don't want to say a critique of the integrated care systems in the UK is a lot of focus on integration and bringing providers together, not as much focus on what are the national measures, what are the goals, like in terms of both patients and populations that you're trying to achieve. What are the ICSs in essence accountable for, other than just, the 4-hour wait for the A&E. I mean, it's like, there's a lot of focus on those process measures and access. I would call them access measures, which are important and we should care about them. But I think there are other measures as well that matter to patients. And so I think, that's really where you got to start with in data. And the last thing I'd say, and I appreciate the comments earlier about the patient. I think this gets lost, and I love I have not heard the original sin reference that, and it's true about healthcare and education, is that generally speaking, the user experience is really bad. And you could ask almost anyone in almost any healthcare system and anywhere in the world, and even in place like the UK, where NHS is a prized institution, people can tell you of bad experiences that they or loved ones have had. And it's just, I mean, they can also tell you about good ones, but it's far too often that the bad experience, and the bad experience may not be that they had a bad health outcome out of it, but it's just the way they were treated, the experience, how their time was appreciated or not appreciated. So oftentimes it's not. I think that when we measure outcomes, we also have to take the patient experience, the user experience into account, because part of the reason why the patient experience isn't focused on is because it's worthless to providers, to the payers, whether it's the government or private insurance. I mean, generally speaking, there isn't all that much consequence in many cases to anyone if the user experience is poor. And I think we got to change that. And I think we need to incentivize through our payment system much more of a focus on the patient experience. And sometimes people will say, "Oh, what are you talking about? Like the quality of the food in the hospital, and it's not good enough, and we need to improve that." No, I'm talking about how empathetic is the health system. How much time do we spend with a chronically ill elderly person on 10 medications? Is that physician to patient experience 5 minutes when it really should be 30, 40 minutes in length? And is the reason we're spending so little time because of the payment system that is, encouraging the way in which care is provided? I think that, we move to value-based care, we need to include whether those are patient-reported outcomes type measures, or even things like just general measures of was this a good experience? Would I recommend it to someone else? I think those are the kinds of things that we need to include, and data and capturing data on that patient experience is I think crucial, because if we don't start making some of the reimbursement to providers contingent on performance in those measures, if we don't collect that data, we can't change those financial incentives.
And Mo, I'll come to you on this, because we talked about asking the patient what outcome they're looking for. What outcome are they looking for? Are they looking for better food? Are they looking for better outcomes? How do we measure what a patient wants?
So Steve, all the research on the outcomes patient wants it's often not the one the doctor assumes it is. So it's not so much about, so the joint replacement. It's not so much about, can I play football or run or dance? It's actually every day I want to be able to walk to the end of the street, to the shop and back. And actually, if we understood that, we might take a different approach to things. Or what I really care about for the cancer I'm in right now is, in 3 months, my daughter is getting married, and I want to be rested enough for that wedding. That's really what I care about. It's not actually the life extension beyond that. So if you get into those details, you can arrive at quite different solutions. And often they're cheaper, by the way, but nobody discusses them in a way that the patient understands. They focus on sort of the national biological metrics that have been set separately from the patient's preferences. And that goes back to part of the empathic approach that Jason was talking about. Actually sit down and understand that person's goals. It's not just the right thing to do, it's also a more affordable thing to do for everyone concerned.
It's also a more holistic approach, I suppose. I mean, Ben, from a payer's point of view, what do you measure and how do you measure it?
Well, yeah, so we always try to be able to measure our customer satisfaction through NPS, but it's pretty rudimentary and we're unable to really see it on how it actually, their customer experience is within their course of getting care. Interestingly enough, though, and really glad to be speaking, from Saudi today and being able actually to see something this morning where when we're talking about data and the collection of data and the right data, but then being able to monitor it. I'm really seeing, a country that's on the right path of being able to collect the right data on the private side, and then being able to have it on a provider by provider basis, on a payer by payer basis. And then even to the point where they're able to do these statistically proven customer satisfaction as well. And they're looking at it and, when in doubt, blame the payer. But, the statistic I saw today was roughly around, let's call it 60% with the providers of satisfaction to 80%. And the payers always being at around 30% as the customer has gone through the process. And so, there's a lot that we need to do. And when I think it was Jason that mentioned earlier that, we really don't look at the patient and their satisfaction. Actually, it's really important to us because one, there's the outcomes. Obviously, in the circumstances that was just mentioned, for someone that is, going through cancer or a chronic condition, that's going to be one circumstance. But in 90% of the times for our members, it's going to be simply going in for, it could be to the ER, could be GP, could be then going to a specialist for something a little bit more minor. But how easy is it for them to get through that process? How fast can they do that? And that is really important because from a payer perspective, if we aren't able to satisfy our members are going to tell their HR. The HR is going to know that dissatisfaction. They're going to move on. This is a very competitive market within Saudi Arabia, UAE, around the world, everywhere that we are. And it's becoming more commoditized. So that customer experience, the patient experience, and how we can be part of that and make it easier for them is really essential. And being able to have that data to be able to help understand the outcomes then after that, to be able to tie into the value-based care, and hopeful for us to be able to then also have constructive conversations and be able to then have the partnerships and a culture of partnership with the providers so we can increase that value-based care, increase the patient satisfaction experience is really essential.
So ultimately, it's about, sorry, there was something like that?
No, yeah, I was saying, it's also on a, patients need treatment per diagnosis. They don't need a certain diagnosis. So it's also our responsibility to provide treatment that makes a difference enough to the patient for the diagnosis. So in value-based care, and that is very active in Sweden, the HTAs of each treatments provided, and would that be the best mix for that patient? And that defines actually the provision of care in Sweden. So it's as important it is to adopt new treatments. It's also important to discharge treatments which do not provide enough gain for the patient. That is very hard in many systems, actually, and even in the Swedish system, to give up things that don't provide enough benefit to the patient. There's a lot of sentimentality.
It's a really interesting point, actually, because at the end of the day, Mo and Jason both make the point, and Ben to a degree, both make the point about what the patient sees as a desirable outcome. But at the end of the day, I guess you take the example of the hip replacement. Well, actually, the patient doesn't really want to try and walk to the end of the street every day because it's going to hurt. Yeah. So should we, should we say, oh, well, actually, no, we want our patient to be happy, we want them to be comfortable, so the physician shouldn't push them that hard. There's an element of the patient to use to bastardize most company name. There's an element of the patient knows best here, but isn't there also an element of the clinician knows best? So where does that line sit? Mo, do you want to come to that? Do you want to speak to that point?
So the one thing I'll just say, because I get daily advice that it's a nice idea, but will you please change the stupid name? What we meant by patients know best is not that patients do know best, but our mission is that the patient knows best. And that includes knowing what the clinician knows, what they personally know about their situation and their family support. So it's getting all the latest evidence and family and support network of the patient together to give that information to the patient. So yes, the clinician may know that you really do need to walk and get through that pain, or that you really need to put that donut down and focus on you can actually improve your health. That faith from the clinician as well as the skill of the clinician is important, but it really it's about letting the patient know what the clinician knows rather than saying the patient knows it up front. But if you combine everyone's knowledge and make sure the patient understands that, then you get, and then you, on top of that, you add, of course, the caring. The physician doesn't just know that you can walk and you should walk, but they care that you walk. They want you to get through that pain because they want you to get the benefits from that. You may not care about walking, but your son or daughter cares about you having that. So if you bring all that, then when the patient knows all that, then they can make the right decision. Again, especially because of long-term conditions, the patient has to understand and agree if they're going to actually carry out the things they need to carry out, and we need them to do so. What the doctor decides is too inefficient, too ineffective. The patient's actions require the patient's agreement and understanding.
For the record, I don't think your company name's stupid at all. I really like it because I think at the end of the day, it gets people to think about what it means and what it means. And I think what the point you're trying to make there, if I've understood it correctly, is that as much as anything else, it's about the patient being able to make an informed decision about what they want from their care. But that still links back to this question of how do you pay for it? So, if we're saying that the idea is that we should look for value-based healthcare and value-based payment models rather than volume-based payment models, it comes back to this question of what do you measure and what do you pay for it? It's a good point actually at which to bring in an audience comment, and also just to let those of you watching know that you have got a big red button on your screen. If you have a question for the panel, please do press that button. I will get an email instantaneously with your question. I can put it to them. I've got a great comment, I think, which relates to what we're talking about here from Rahul. More a comment than a question. Systems sometimes use benchmarking alone as a measure to define value. And we need to be careful while doing this and look at the overall system concept. What is their community infrastructure support system? What is variability driven by? And is it really unwarranted variation? Before we push systems for reduced spend per patient, are we sure that we've got the right dimension of real cost per patient measured in the right way? I think that speaks largely to what we've been talking about, doesn't it? What we don't want to do is say that value-based care is a stick with which to beat our costs down. It's about, value by its very definition is quality against payment, isn't it?
Change of
Guys, I'm very happy for you to come in, but just stick your hand up for me so I know who wants to come in. Jason first, then Stefan.
Okay, just my point on this is where I think that question or comment is getting us to is why incremental improvement is so important, in the sense that various health systems, whether you define that as a nation, a region, or a group of providers, in our US context, we call them sometimes accountable care organizations, ACOs, whichever of those groupings you're looking at, you need to look at a baseline of performance and then incremental improvement on top of that. One of the quickest ways for value-based care to go off the rails is to start holding providers or regions or nations accountable for achieving objectives that are basically impossible to achieve. And we've seen this a lot around the world, where you create this benchmark and you say, well, why aren't you at that benchmark? Or you set a goal, why aren't we at that goal? And that does not take into account the unique challenges that a community, a group of providers, a group of patients, and those challenges can transcend the four walls of the health system, and are things, in some cases, the health system needs to see that as a challenge, embrace its community, think about what it can do to do it, but to expect it to just flip a switch and automatically, make all those issues go away is unrealistic. But also, I think it's important to say that, yes, there are factors outside of healthcare that drive, as I referred to it earlier, bad variation. But because that exists and exists in any country, in any system, as I say, the most complex patients in the world, patients with, comorbid behavioral health like schizophrenia, substance use disorder, are chronically homeless, have multiple medical conditions. Those types of patients, they challenge any system. They challenge, whether they live in the Bronx in New York City, or they live in, London, or they live in anywhere else in the world. Those kinds of patients are hard and difficult for everyone. But I think at the end of the day is that we need to accept the fact that just because we have patients like that, just because maybe the social services in the community are not adequate, doesn't take us off the hook as a health system for trying to make incremental improvements and to do better. And that's why I think at the end of the day, one of the key things we haven't really discussed today in this discussion, which has been great, is value-based care as a movement, as a journey, should also be about continuous improvement. We should embrace as a health system that what we're constantly trying to do, this is why data and measurement is so crucial, is that we have to identify what our goals are and incrementally make progress towards those, understanding we're not going to get there next year or next week, but it's going to take us years. But we can't just also say, well, the problem's too big. There's too many challenges outside the health system. We can't possibly do anything. Woe is me. And I've seen a lot of healthcare providers say that exact thing and say, it's not my problem. It's society, it's the patients, it's the community, it's the poverty, it's whatever. That's the reason why we have bad outcomes. Well, I get all of that, but we also need to acknowledge there's more that we can collectively do, both clinically and socially, to help advance the society and community. And so that's why I think it's also really important, to collect that data, set those metrics, and then adopt a philosophy of continuous improvement.
So there's a point there, isn't there, about, okay, you want to set, at the end of the day, this comes to value. Value is the axis between quality and cost. That's the definition of value. So from that point of view, one of the issues here becomes, if you want to make payment based on outcome and based on quality of service, how do you create the measure that sets that metric? Because that's a really difficult thing to do. There are certain things, as you say, where there are social determinants or whether there are almost kind of amorphous benefits, if you like, where it's really difficult to actually set a metric that an insurer like Ben could pay against. But at the same time, even when you're trying to do all of that and create a metric that works, what you're also saying there, Jason, is you've got to keep that under review constantly because you want to make those kind of incremental improvements. It's a fascinating question. Stefan, you wanted to come in, and then Ben, I'd like you to come in.
No, that was my point. No system will ever be perfect, but you can have the ambition to become perfect, and that's what it is, a moving target. That was my pitch. I think Jason did it very elegantly, but so many aesthetic organizations have been formed under the don't let the perfect be our biggest enemy. So you aim and you have to re-aim. That's so purpose, because things change, demographics change, the treatments available change all the time. So we just have to embrace what we have with the cards we have. And I look very optimistically on the future, because we are getting into the big data where we real time can monitor our moves. So I look optimistically to the future, but it's all about not trying to be perfect, trying to become perfect.
And there's a really interesting point here. And before I come to Ben, so I just want to bring this one to you, which is, of course, that you are in a unique position in Saudi Arabia, where you are trying to create a new healthcare system to all intents and purposes. How are you going to, what Stefan talked about there in terms of kind of create you can't create the perfect health system. How are you trying to learn from these different systems and things around the world? How are you going to try and create the best health system you can at this point?
Yes, Steve, can you repeat the question, please?
So for example, there's a great example here, which we're talking about data, and we're talking about so how could you use the work that you're doing in terms of population health management, in terms of kind of understanding disease profiles, understanding what the needs of your population are? How can that influence your payer model? Can you create these measures that insurers like Ben could pay against, or your national insurers can pay against?
Actually, it's the issue also here in Saudi Arabia. How we are going to collect the data, analyze the data, it's still issue, and we are facing difficulty in that. So choosing the right measures and standardize it and framework all these measures, and then find a good system that collect the data and analyze it. It's very difficult, but we are trying to learn from other countries how they are implementing that, and we are trying to reach that level. But still, we are facing issue right now, and we are trying to collect as much as we can data that we can base our information on it.
No, that's useful. Ben, come back to you then with the points there that Stefan and Jason particularly made. How does that kind of incremental improvement, how does that measurement of sometimes very difficult to measure variables, how do you turn that into a model that a payer can pay against?
Yeah, so I think that the concept that this is a movement, and then beyond that this is a culture of partnership that's needed. And if you don't have that partnership with your key providers, and that's going to be coming from an alignment of goals, alignment of long-term outcomes, setting the right, I hate to say it, KPIs, but just understanding what is it that we want to achieve and taking it from just a base level and building. Continuous improvement is absolutely what it is. And it doesn't happen overnight, and unfortunately, fee for service is a model that has been adapted around the world in the private side, unless the regulator has said otherwise. And at first, but then, as companies start to mature, they start to, figuring out that 20% of their volume is going through one provider, being able to build up then the right partnership and then alignment along the way. Because we can also, as an insurer, maybe we could try to encourage our members to go somewhere else, but the best outcomes and the right customer experience might be at that one major provider. There can be ways that we can come together and say, okay, how do we find this alignment together? And so I would just say, just to answer the question, it is going to start with probably baby steps along the way, and that fee for service, turning a couple of these contracts then into having some components of value-based care, being able to track major episodes, being able to understand the cost. How do you understand the components that are in there through transparency and the data, not just trying to drive down cost, but understanding what's within there and making sure that we're getting the right outcomes for our members, customers, and the provider's customer as well.
Thanks for that, Ben. We've got another audience comment here from Magdi Ayub. Apologies if I pronounced that incorrectly. Achieving value is dependent on many variables related to quality of care and compliance of patient. How would a value-based health system be able to account for both variables and ensure fairness of assessment? I guess that speaks to this same point, doesn't it? Which is actually in some of these more difficult, how do you define an outcome?
Yeah, I'll say, I'll give it a shot on this one. Is that I think each whether it's however the health system is organized, whether it's at the national, regional, or even local level, is and it to Greg's saying, is up to policymakers to decide to what extent they want to insert themselves into this process. But ultimately, it's up to that unit to decide what is value-based care. What are the outcomes that you're trying to achieve? And that process of selecting those measures and deciding where to focus this large, highly complex system to focus on, what those are, that is a challenging but essential task. If you don't, no decision, meaning you don't define it, is a decision. Like it will lead to a set of outcomes, and those may not be outcomes that you remotely want. So I think every society, in essence, needs to decide what those goals and metrics are, and what are the right measures for Sweden, or for New York, or for Saudi Arabia, are going to be invariably different, and appropriately so, because the countries, the regions, the culture, the challenges are inherently different. Because I think that's the other thing, is that the setting of these objectives is not done in a vacuum. It's inherently done based on not only the values of the society and the goals and objectives and priorities, but it's also a reflection of the challenges that you have today within the health system in each of these different places. And, in the US context, we have a lot of waste and inefficiency, and a real concern about whether or not, how much can our society afford, right? The runaway train that, Ben talked about globally is really a true story in the US. And I think for me, as American, a lot of our focus has to be about slowing that train down, trying to achieve efficiencies at the same time we're improving. We got to take costs out of the system, or at least slow the rate of growth and cost. But in the UK, the issue is not total cost. It's you probably spend too little, right? But you have inefficiency in the sense that you have a finite amount of money, and how do you get the right set of services and serve as many people as you can in the most effective fashion? You have inefficiencies like we have inefficiencies, but some of the core challenges are maybe a little bit different. But taking that context into account to say, okay, based on those challenges and our societal goals and objectives, what are the right set of measures? But if you don't define what those are, you're rudderless, right? You don't have that North Star to point this big system to. I believe at the end of the day, the financial incentives that value-based care is all about, how we pay providers, can be very, very powerful tools to get you towards your North Star. But you got to have the North Star, and that has to be the outcomes. It has to be the measures that the community, the society sets.
Jed's no longer with us. He's obviously had to go and operate on his patient. So I'll attempt to kind of speak certainly my own view as far as the NHS is concerned, based on what you've just said there. And then Stefan wants to make a point. I think the NHS issue is a really interesting one, because, as you say, it is a sacred cow to the UK population. You have got a situation where, because it is free at the point of delivery and funded through taxation, there is always going to be an absolute hard limit on the level of spend that can go into the system. So as a result, you've got this issue whereby we have to drive value-based healthcare. We have to drive outcome-based, cost-efficient models, because otherwise the system simply falls apart. You simply stop being able to actually provide care to people. Whether that is sustainable or is another point entirely. And I think what you just talked about there, Jason, and what I've just said about the NHS, both point to a point Ben made very early in the conversation about the level of inflation in healthcare spend and the increase year on year that we're seeing in healthcare spend. Stefan, you wanted to make a point.
It's imperative when value-based healthcare, we talk about patients and diagnoses and what parameters to set up, but different healthcare systems have different stresses and healthcare challenges. So have a value-based healthcare on the meta level. For instance, in US, the life expectancy in males are decreasing, and that needs to be addressed on a meta level towards the providers as well. What programs should be given? We in Sweden have other challenges. So when that's what I would say, the intent of value-based healthcare is to refocus for the patient, but we shouldn't be narrow-sighted. It also gives us, we also have the nations or your provider area as a patient.
A very, very good point, very well made. I think we've got 10 minutes left. So I'd like to focus for that remaining 10 minutes on the future. You know, Jason, you talked about the idea of value-based healthcare being a movement, and I think I expanded that into a journey. Where does the journey end? Where do we ultimately want to get to with value-based healthcare?
I think Stefan said it earlier. I think you said it exactly right, which is it is a journey. I mean, I do think, though, at the end of the day, is that you should set outcome measures, and I do think this is an advantage of a more nationalized systems, is that you do tend to think of health system on a more of a national level. We in the U.S., if we think about national in healthcare, we're usually talking about public health, in meaning like public health measures and things like that. But we tend not to think about it. Now, we do have some structures in place, like the National Center for Quality Assurance, that has health measures that cut across lots of insurers. But our system of measuring health or I would say more truly, the effectiveness of the healthcare system itself is not as centralized as you are. And so that means at the end of the day, it's the decisions about where to prioritize and how to define the end goal is left to a lower level. Now, there is a benefit of that approach, which is you have lots of different people across the nation of 300 plus million people making decisions about what to prioritize, what strategies to pursue, what measures to use. Now, there's some standardization that exists, but it is a lot of people trying a lot of things simultaneously. And that has some advantages in the sense that we can look across the country and see different things being tried in different ways, which hopefully as a global society, we can look to which ones work and which ones don't. The one challenge at the national level is if you don't get it right, like if you don't set the measures, is that it ripples down and it affects and drives an entire system that affects an entire nation. And so there are benefits to that national definition of what is a value-based care system in the sense that you can drive it effectively. But there's also the downside, which is if you don't get it right or you fail to really address that core issue, what are your goals? What are the measures? What's your North Star? If you don't define that, you're a rudderless ship and you've missed out on the big, powerful opportunity that a nationalized system has, which is to set that star and drive that complex, powerful system towards it. And so that's why I think in our US case is we don't have that level of nationalization. And so therefore it's left and those decisions are made at a lower level.
It astonishes me every time I go to the States that it's the only country in the world that I've visited that doesn't have a centralized national ministry of health. And that must make it incredibly difficult because the disparate nature of the system essentially means, you know, you're pursuing as many goals as there are states, payers, stakeholders within the system, aren't you?
Yeah, I mean, we have a Department of Health and Human Services, which in theory is our Ministry of Health, but its primary roles are a very large purchaser, meaning that they run government programs, Medicare, and then regulate Medicaid, which is run by states, but it has a major regulatory function. So it's a payer for a big swath of the population, but not most people. And then the second thing is that it is like a regulator to a bit, but also a public health entity and runs a bunch of sort of public health related type programs, which touch small aspects, relatively small aspects of the delivery system. Now, as a payer, and it's true, is Medicare does have the ability to drive policy. So one example is, and it's driven policy globally, is how the US pays its hospitals, right? The DRG system, Ben made this point earlier, is that fee-for-service, it gets adopted and has been adopted in countries around the world. And unfortunately, a lot of the adoption has been around the DRG system of hospital payment, which was adopted. And the reason we have that system in the US today was because Medicare got tired of paying per diem incentive for more days in the hospital and decided to do, in essence, a version of a bundled payment. You could argue that it was the first ever value-based payment, but it was basically a DRG, a cap on the amount of payment for a procedure in a facility, which then flipped the financial incentive to the hospital, which was to discharge people much more quickly as opposed to just having them sit in hospital beds for long periods of time. So that was when Medicare changed that policy. We had basically very quickly universal adoption of value-based or that particular model. And that's still the primary means of reimbursement today. In the US today, we also have Medicare, once again, still, I think is the primary driver of value-based care. And we have national goals, but it's more like Medicare pushing it, encouraging the private and the states who run Medicaid to continue to push for it. But it's not as strong of, it's an influence, but it's not the command and control that you have with the NHS, where you can change a policy and then it applies nationwide.
So another country that sort of sits in the middle of that model, because you have both regional and national oversight, Sultan, is your own in Saudi Arabia. And obviously the transformation program will ultimately lead to a value-based healthcare national insurance system on the public health side. How long is that going to take? When do you think we're going to be in a situation where we see the transformation starting to bear fruit in Saudi Arabia?
Yes, Steve. The value-based care, we cannot do it all at once. So it needs a small step to move forward. So what we are trying to do in Saudi Arabia is to focus on three things. Create outcome measures to move from volume to value, and to move from the quantity to quality. The second thing is to implement a payment model to support this goal. Last thing is to improve the digitalization infrastructure and how we can collect the right data in order to improve patient quality care.
And what's the timescale on the transformation? When is it that you expect to see this fully operational?
Actually, there is no. As per my knowledge, I don't know what's the time scale, but as soon as possible, because this vision is we call it 2030 vision. So we expected to implement all these things by the 2030. A
lot still to do. Mo, where do you see value-based healthcare going from a patient perspective?
I think it's going in every regulator in every country. So everyone wants this. I think what's coming from the patient's perspective is the data availability is much wider and much deeper and much faster from the patient, because of not only the phone as a device that collects data for you, but all the new diagnostic devices that are going to be in the patient's home. So it's not just the Fitbit that tracks your movement, but it's on your phone, but actually it's the flashlight on your phone that can check for the arrhythmia on your finger, which nobody imagined 2 years ago. So those data sets are coming directly from the patient and serving the patient. So if you can incorporate that with everyone looking for the value-based care, I think that's the revolution that's coming in 2030 timelines as well, Sultan. So,
Stefan, from your point of view, what's the destination of the value-based healthcare journey?
I'm a AI and computer freak, so I think that a lot of the future comes with the accessibility to data and to be real time with short notice to pick up signals of unfavorable outcomes, but and based on Internet of Things and smart gadgets, of course. So it's very much. I think it, and I think that will define where value-based healthcare, because value-based healthcare is knowing the outcome, and the development is coming in how to get and what type of outcome we can get.
Knowing the outcome and then paying for the outcome, which usually, of course, lands at the feet of the insurer. So last word to you, Ben. How are all of these innovations going to get paid for by insurers?
Well, we're going to have to keep paying them, and it's going to be at the bill of the customer at the end and the client. And it's our us working together to make sure that we can get a better outcome. I would divide this into two, one, and I can use this in a Saudi context or into other markets as well that we're operating in. On the private side, data is becoming one of the most important things. We're at an incredible fortunate moment that we have more than enough data, or starting to get a lot of the right data. Is making sure that we're collecting the right data, tracking the right data, as we've already spoken about. So I very much support that. After that, making sure that we're starting this partnership together with our providers and being able to say, what is this movement that we want to do together in partnership, and how do we want to measure that? And it's going to start small, particularly in a lot of markets that we're operating in, and the people are on this call right now. But being able then to have that evolution and continuous improvement, I think that's a very important piece for us to be doing on the private side. On the public side, or in some of these public-private partnerships that are starting to come about, and Saudi Arabia being one, there's other markets in the GCC that are doing this, of how we can make sure that as a payer or as an administrator, as some of the private side that's here want to participate in it, having that alignment with the government, working together in consultation of what does value-based health look like, and making sure that there can be that alignment for sustainability in the long term. Because a lot of the governments, just as you spoke about earlier, Sultan, it's public right now, but we want to find ways to be able to privatize, lessen the burden from the government that's happening around the world. So that partnership, that collaboration, and understanding about what value-based health could be, and that's going to be the future, to be able to help us continue to pay the bills, be able not to cut costs, but be able to get the best outcome at an affordable price.
Thanks very much for that, Ben. Well, look, that's it. We're out of time. Thank you to Jason, to Sultan, to Mo, Ben, Stefan, and Jed. I hope the operation went well, Jed. One thing that we can all agree on, I think, is that the value-based care is the future. It is a movement. It is a journey. It's got some way to go. And Healthcare World, well, I'm sure, will be bringing more conversations like this to bear, and more conversations about this in the future. Thank you very much for joining us. Look forward to seeing you on the next Healthcare World series. Thanks very much.